keyword here, because please feel free to speak up at any time and ask questions about it. As Marnie said, one of the hopes of these kind of small group discussions is that we can answer any questions, and you know, sometimes in a webinar format those things just fly by and there's so much information that it's hard to remember what you were going to ask. So at any point, ask questions. The email that we sent out, I believe it was last week, talked about something called our Countdown to Promoting Interoperability series or program. And that's really a fancy term for a series of sessions or a series of articles that we're going to be sending your way to help you understand what the requirements are within this Promoting Interoperability category in 2019. And that's the category that focuses on how you use Revolution EHR in your MIPS participation. So we feel that we can give you a lot of good information in that area and give you a really good head start on what needs to be done. So with that in mind, we did publish a couple of ideas or a blueprint or a roadmap, if you will, in one of those messages about ways that we think you should approach 2019. First and foremost, one of the key ideas is you cannot start a Promoting Interoperability performance period until you are using version 7 of Revolution EHR. And you've probably seen system messages or notes about that within the application now, because that is going to be released next week. So if you entered 2019 in January thinking that you were participating in a performance period, it's important to recognize at this point that you weren't. You're not allowed to do that until you're using that new version of the software, and that's coming out on Valentine's Day. How appropriate. You do have any 90-day period of time that you're allowed this year. And that's up to you, when that 90 days is going to be. It doesn't have to be aligned with a calendar quarter. It can be any 90 consecutive days. But it can, again, it cannot be until at the very earliest, February 14th would be the start date of that period. Now, our position is that there are going to be a number of changes that you need to consider. And I think this group is probably better prepared than any other group that's going to be approaching this category this year. But there are some things that are just going to take some time to make happen in the practice. And one of those ideas involves exchanging information with other providers. We're going to dedicate an entire session to that measure. I believe probably 2 weeks from now, 2 or 3 weeks from now, we'll be talking about that specifically and giving you some ideas for success there. But because there's some new ideas, it may take a little bit of time to find success. So what we're proposing to you, and I would love it if you guys would provide feedback or argue with us, we are saying between now and March 31st, let's get really, really comfortable with what the expectations are in this performance category. Even though I just said a second ago, you could technically start next Thursday when version 7 is released. Again, there's going to be things that you need to learn about workflow in that software. So maybe we consider the start of the second quarter of the year as your first attempt at success for a 90-day period in 2019. If that works out really well for you, then great. Then you have the final 2 quarters of the year to see if you can enhance that score some more. And ultimately, if you're not successful over that second quarter, then that's okay, because now you've learned some things about what you need to do to be successful, and you still have the final 2 quarters of the year to achieve success. So that's what makes sense to us. That's what that's why and how we've laid out this program that we're going to be delivering you over the next 7 weeks. But I'd be curious to know if there are any questions about that introductory information or any questions at all.
I don't think so.
You sounded really far away.
I'm sorry. No, I'm good.
That's okay. I was just teasing you.
Hey,
So,
Brett.
Yes, ma'am.
Are they going to put the new version out on the trial? I'm sorry, on the one that we can just go out and play in? Are they going to? Is that version going to be out there so we can practice things?
Yes, it is. Yeah, I believe, and Marnie and Libby, correct me if I'm wrong, I believe it is available on the sandbox now.
The sandbox. Thank you.
Do you have your credentials and everything? Do you remember all that stuff to get in there?
No, but I'll get that after this call.
Okay. So if you do come across anything odd in there that you have questions about, obviously let us know.
Okay, thank you.
Mm-hmm.
Are there
So
so
is
many
any,
changes
oh,
in version 7 that we really need to get in the sandbox and poke around for that?
I think that's probably a personal decision, but I would tell you that from my perspective, probably not. For example, there's not going to be like screens that you're used to using. You're not going to find them missing or move to a different location. Much of the stuff that has been added for version 7 is stuff that you won't visibly see. It's stuff that's happening under the hood of the software to make it easier for you to share data with other providers and your patients and their families. So I don't think if you didn't poke around in the sandbox, I do not think that next Thursday would come around and you'd feel lost in any way, shape, or form.
Okay, thank you.
Mm-hmm. Has anybody watched any of the webinars about 2019 that we've produced to discuss some of the changes, or is that something that we just haven't had time to do yet?
My boss has, the doctor, but I have not. He asked me to jump on this for him today.
Okay. Who's your doctor?
Dr. Gordon?
Okay, yeah. The reason I ask is one thing we didn't want to do in this introductory session is to bombard you with a ton of information about what all the new requirements are, right? That would be effectively what we did in the webinar, and that's not how we want to tackle this. We want to do this in a very straightforward manner where each individual session of these we're going to devote to one specific measure, and we'll be able to answer any and all questions devoted to that measure during that session. So what we really want to do today was provide the opportunity to have a little bit of discussion around it, but also just put this roadmap in place and see if it made sense to you all as people that are driving these things in the practice. I know it can be sort of weird to hear us say, well, you're not going to be officially doing anything till April. But for those who have been around a while, you may remember back in 2014, it's really the same way that we approach stage 2. You know, back then, nobody could start a performance, well, I guess it was called reporting periods back then. Nobody could start one till April 1st. And the time was spent, before that, was spent educating and learning about the things that need to be done. And that's really no different than what we're doing here. So we're certainly willing to talk about any of the deeper details, but at the same time, that wasn't the goal of this discussion.
Brett, I'm probably in the next meeting you won't get us to be quiet because we'll have so many questions.
Yeah, we should find a happy middle ground. Let me give you this. At the risk of providing too much information, and I would ask you to tell me to stop it if I provide you too much information. Let me go over this slide just to give you a very broad overview of what we're going to be covering in the next few weeks. For those of you who haven't been able to pay any attention to this stuff to this point, and that's absolutely okay, you may remember that in previous years, there were tons and tons of measures that need to be paid attention to and you need to be successful with. Heading into 2019, Medicare has revised the whole program again in their eyes to focus on just those things that make it easier for doctors to share information with one another, or just those things that would track doctors sharing information with each other or their patients. So instead of having 10 measures that all have like statistical thresholds that need to be met, you're now only going to have 4 objectives, and they are in the first column on this slide: e-prescribing, health information exchange, provider to patient exchange, and then public health and clinical data exchange. That's it. You won't see anything like secure messaging anymore where you were graded on sending messages to patients. You won't see anything about view, download, or transmit where you were graded based on a patient maybe doing something for you, but most likely they didn't do something for you and it ended up hurting your score or not helping you. And even patient-specific education, those things aren't here anymore. It's just these 4 objectives. So if we look at the measures that are associated with these, e-prescribing is pretty straightforward, right? It's the number of prescriptions that you write that you'd send electronically to a pharmacy. Health information exchange, you'll see that there are 2 measures. One involves the situation where you send a patient out to another doctor, it's expected that you're going to provide that doctor with an electronic summary of care document. And for those of you who haven't seen that document before, it basically prepares that other doctor to care for the patient by providing them with important information like the patient's medications, their allergies, their problem list, things like that. Now, the second measure of health information exchange is almost the exact opposite. When you're receiving a referral from another patient, from another provider, they have to send a document to you, and you have to use that information to build the patient record in Revolution EHR. So if it's an existing patient, you'd simply be using that information to update the patient record. But if it's a brand new patient, you may be using that information to efficiently and accurately add med lists to a patient record in Revolution EHR just by clicking the mouse. We'll highlight that process when we get to that session, and I think you'll find it pretty interesting. Provider to patient exchange, that one is no different than the old measure where you used to provide patients access to their clinical data through Revolution PHR or the patient portal. It's expected when you see a patient that you're going to give them access to their information within 4 business days. And that information is automatically made available to the patient in the portal by your signature or by the doctor's signature on the encounter. So that one's going to be a pretty easy one to satisfy. But again, we'll talk about that fully in the weeks ahead. And then the last one is probably the one that'll create some questions. It involves registries. And the expectation here is that you do something called actively engage with 2 types of registries. And active engagement can be as easy as you registering for 2 different types of registries. Now, there are lots of exclusions, as there have been in the past for these registries. There are exclusion options. So if we're looking at this list and we're saying immunization registry, I don't know any immunization registry that's going to let me participate, then you'd be eligible for an exclusion there. So when we look across these things, the column to the far right shows you the maximum number of points that you can receive for a given measure. So if we're looking at, say, e-prescribing, you can see that's worth up to 10 points. And let's say 90% of my prescriptions were sent electronically to a pharmacy. I would receive 90% of those 10 points, or 9. So said differently, the more I do these things, the better. But the absolute requirement is that I do these things at least 1 time during the course of the year, or during the course of my 90-day performance period. If I don't do that, then I'm in trouble, right? That's where I would end up not getting a score. I should also throw in the idea that there are exclusions available for these other things too. So using the example of e-prescribing, let's say you knew your prescribing volume was going to be low during the year, and maybe you couldn't see fit to invest in an e-prescribing system based on that volume. If you write fewer than 100 prescriptions during your performance period, you have the ability to exclude from that measure and avoid the need to do that at least once during the year, if that makes sense. So there is some flexibility still built into this, but these are the measures that we're going to need to be successful with over the course of the year. Oh, and by the way, the point values then, what you achieve through your use of Revolution EHR for each measure then gets added together, and that's how you ultimately arrive at your final score for the category. So again, the better you do across all these measures, the better your final score, and then the better that final score is, the better your chances for increased reimbursements in the future. So again, that's really why we want to focus on each of these things in their own session so that we're all comfortable with what's going to be expected of us. But definitely willing to answer any questions about any of this, or if any of what I just said doesn't make sense, let's talk about it.
Does Rev currently have the ability to help facilitate the reporting in those 5 public health areas?
In terms of like actually integrating with different types of registries, right. Not at the present time. Okay. Again, from a requirement standpoint, however, that will not stop you from being successful. Let's say you were aware of a registry that you wanted to participate with, and you signed up and you registered. That is considered active engagement. That would afford you credit for that registry involvement.
How does that get reported that way?
It's an attestation. So during the data submission process, the files that we prepare on your behalf would actually say within them that the active engagement for registry X was satisfied, and then we maintain the proof. So you would probably receive a registration confirmation letter, and we would maintain that in our files for you, so that if an audit ever came your way, then we have the easy ability to support the response with that documentation.
Okay, I get that. Thank you.
Mm-hmm. What state are you in?
Maine.
Do you ask that question from the perspective of having knowledge that there are certain registries that require your providers to do things?
No, I am not sure if we have to do any of these at this point. That's something that I need to look into. The doctors within the practice may be more aware of that than I do. So I'm just kind of gathering questions that I have.
Mm-hmm. Yeah. The biggie on here, and Marnie can talk a little bit about the states that we're aware of that require syndromic surveillance reporting. But the big category on here as far as optometry goes, or the common one, is clinical data registry reporting, because that's where AOA more falls in. And most optometrists will probably, their participation in this registry category will probably come down to a question of, did I register with AOA more or did I not? And if they did, that means we'll be claiming an engagement on their part for clinical data registry. And if they did not, then it probably means we'll be excluding from the majority of these things for that provider. And that's a perfectly acceptable path. If there are no applicable registries out there, then you can't really be expected to engage with things just for the sake of doing so, right? The whole point of this is for it to be useful. And if it's not going to be useful, nobody's going to expect you to do it.
Right. Okay.
This is Marnie. I'll just chime in, and Ohio and Kentucky, I know, are two states that they don't make any exceptions based on provider type or specialty in terms of their syndromic surveillance program. So they do require everyone in the state to register and enroll. But we'll help you kind of do a scan of the country, essentially, and see what really is available for you to engage in. Illinois also wants all prescribers to enroll in their PDMP, even if there's no integration immediately available. So those are things we'll keep an eye on for you.
I realize I glossed over the bonus options that are there. Those are in the e-prescribing objective. Those are related to doctors who prescribe Schedule II narcotics. And again, I'll admit that I don't know all of the state privileges that optometrists have, but I don't know that too many optometrists are writing prescriptions for Schedule II narcotics. So those probably will not come into play for any. I shouldn't be that broad. For very many, if any, let's say it that way, optometrists.
Hey, Brett, this is Arlene, Alabama. And this question may have been answered, and I'm going to be learning it as we go forward with this. But on your electronic, when you're talking about receiving and sending information from doctors, is the software being changed? I know currently we can receive, but it's pretty clunky.
Mm-hmm.
It's not time prohibitive for us at all. Are there going to be some changes coming forward on the way that we're going to be able to format differently for software today that we receive that today's process doesn't work well for us? Will there be some changes or some different choices that we'll be able to use to be able to download easier?
There are, and I would probably ask you to explain, whether we do that in this call or outside, explain some of the areas of clunkiness so I can see exactly where you're experiencing challenge. But part of the certification process involved in version 7 was enhancing all that process and speeding up the electronic incorporation process. So my answer would be yes, but I would like to talk more about, where you found challenges with the existing system. For example, are you're receiving files by the sound of it from other providers? Is that correct?
We receive them from providers in the hospital.
Okay, and then you're taking those through through the incorporation process?
we are.
Okay. And where do you get bogged down? Just the overall process of it all?
In the initial part of it, and Dr. Snorbus he'll want to be in on this as well. So if it's okay with you, I'll schedule us a little time outside of the call.
Yep.
Okay.
Absolutely. Yeah, one of the ways that we tried to, and I certainly recognize that there are some time challenges with it. For those who don't know, Arlene's question involved a process that we're going to be talking about involving this measure right here, support electronic referral loops by receiving and incorporating health information. And the idea is anytime, as I said before, when you refer a patient, or one idea that we're going to talk about is when you see a patient that you've never seen before, it's going to be expected that you receive an electronic summary document, and then you build the information from that document into the patient record in Revolution EHR. And it can, in the past, it can be a time-consuming process because there are a number of steps to it where you have to save the file to the patient record and then click on the file and incorporate go through an incorporation process. And some enhancements have been made in that area. But ultimately, what you're going to see is a side-by-side comparison of the information that's coming from the other provider to the patient record in Revolution EHR. And through that process, you can start to make decisions about the information that you'd like to build right into the patient record. So no longer are you needing to manually transcribe information from a paper-based medication list. With a click of a mouse, you're able to drop that information in. So I always try to think about it like those patients that we all sort of dread that come in and they hand you their history form, and they have like 10 or 15 medications on there, and it's going to take you a while to do it. This process is meant to make that more pleasant for you, as well as a lot more efficient and accurate. Anybody want to see that? I mean, I don't want to go against our plan here, but it's a good question that Arlene brought up, and I
Brett, I was sitting here thinking about the example that I could give to the team, and we may be the only, person out there that's having the trouble, but when we bring in, I think I've talked to Marnie about this, but when we I know I've talked to Revolution Support about it, and there was no solution for my issues. But the way that the files are formatted that we receive, you can't find easily the patient name. So
okay.
For me, my initial problem is getting the data so I can find the name. Once I find the name, I'm in good shape. It's finding the name where we're having our experience and our problems.
Understood. Yep.
Present for the patient. Mm-hmm.
Got it.
But you'll have to see it to believe it, because we've done several WebExes, where we share our screen, and yep. they're saying that for now that's the best we can do because of the software that the other vendors are using, or the files that we get. They just aren't very compatible with what we have.
Okay.
Okay.
Yeah. I'd be curious to talk more about that too once once both of the systems have their 2015 edition in place. I'd be curious to see what changes, if anything, and right. if it doesn't change, finding a way to enhance that for sure.
Super. Thank you.
Anyone have any questions about what's on the screen now or this screen? I know we left that one up for a while, but just in case anybody else has joined, which I see some new names.
This is Marnie. I'm interested to see what people think about this whole idea of setting like a trial run for your 90 days in the promoting interoperability category. Does that concept make sense? We really didn't talk about it much last year, but I think it's the best approach going forward. So anyway, I'd just be interested to hear what people think about it. And it's okay, you can unmute yourself.
So Marnie, I'm not shy. This is Arlene. I'm very interested in it. I think it's a great concept.
Very good. Anybody else? I think that the goal was, and like Brett said, when we first started with meaningful use, so many years ago, we had to approach it this way as well, because we didn't have all the tools and we didn't have everybody up to speed in training, for example. So, and then our goal is that maybe if your trial run turns out to be pretty good, then you can concentrate on other things the rest of the year, or just concentrate on getting even better. And it really may take others in your referral network, for example, to come on board and help you out in terms of scoring. So
I know Dr. Gordon has looked at it, and he really thinks, sees it as valid, and it's a learning process to get us to report at the max level we can, and that gives us a great opportunity to do that and evaluate how we did.
It's a great point you make, because when you look at the point values that are assigned here, you're going to have 40% of your score in this category coming from your ability to share information with other providers. And even if you know exactly what you need to know, which you will by April 1st, that doesn't guarantee anybody else knows. And with how other providers have approached this stuff historically, it will probably take the providers in your community a little while to get on board with at the same knowledge level that you'll be, which means your score will probably be better later in the year than it is early in the year. So that's why to us, it makes even more sense to take that first, that second quarter as a trial run at things and really start communicating with others and seeing how close they are to getting on the same page as you.
this is Marnie again. I have a question for the group. Other than Arlene, because she's already spoken up, how many of you are sending, or even more importantly, are you receiving anything from others who are referring patients to you? Have you been able to establish that connection? Is there either through direct messaging or even through a health information exchange or something that is made available to you by a local healthcare organization via their system? Just wondered what you're seeing out there.
Brett, this is Dave James from Wisconsin, and unfortunately for us, I've been at the University of Wisconsin, talked to optometrists that work there and the people we refer to, and they're saying they can't do it. And I'm going to meet with their tech people now, but we haven't done a single one. And you know how hard we worked on it. And Davis Durdeen doesn't do it, and one of the other ones doesn't. So at this point, they're all saying that this is something that, because they're in a big system, and they're all done through Epic, and they cannot do health information exchange direct through their. And I think I've been talking to the wrong people. I've been talking to the doctors. They don't have a clue. So I am going to be talking to a tech person about 2 weeks from now. But at this point, we've had, you know. We have to exchange with our fellow Rev people. Like I'll work with somebody like I used to work with Scott or somebody that has Revolution and exchange that way.
Yeah.
You know,
no, Dave. Oh, sorry. Go ahead.
Yeah, I don't know what to do. I mean, it doesn't. Yeah. It's not getting better. And you know how hard we work.
Yeah, I think you're going about it the right way. I can tell you definitively that we've worked with, I'm thinking of one provider in Connecticut as an example. She had the same challenges with Epic. And she was looking to exchange information with the Yale New Haven hospital system. And what ultimately happened is we were on a call with the Yale New Haven health system and an Epic representative, and it was all sorted out very quickly, and they're now sharing information back and forth. So you may be right about what you said about not talking to the right people, but I also don't want to blame you, right? You just have to find somebody beyond the doctor to know, because I fully agree with you that I've talked to, as an example in my area, I talked to a practice for probably 6 months. I was seeing the other providers as patients of mine. And I said, boy, I sure would love to share this information with you electronically. Can we do that? And they had no idea what I was talking about. Eventually saw the practice administrator, and I said the same thing to her. And she said, oh yeah, that's our preferred way of sharing information. So the doctors often have no clue what's going on, because a lot of times the files are processed outside of their reach. Sometimes the files go to an administrative address, and then that administrator will actually get the files into the record and incorporate the data. So often going to an administrator or an IT team is more fruitful than talking to the doctors themselves.
That's interesting, because Epic sits about 5 miles from where I am right now. Yeah. And I even tried to go over there once, and that didn't go over at all. So I will try that with UW.
Well, you definitely can't say you didn't try if you actually showed up at their door.
Yep.
Dr. James, this is Marnie. We probably talked about this, but at one point, UW Health, because I'm in Wisconsin, I'm just on the other side of the rainstorm right now. Supposedly, there's just one big admin, direct email address, and then everything comes into the UW Health system that way, and then it's sent from that one point of contact. But I don't know if that's still true. I don't know how, WISHIN, the Wisconsin Health Information Network, works within all of that. One question I put out on the chat too is if anybody's connected with primary care providers, to see if that maybe would be a better connection, especially for, like Dr. Papke said, with new patients coming in with big, long medication lists. So I wondered if anybody's had success that way or even thought about it. We were thinking for so long about just outbound referrals. I scared everybody away with that question.
Marty, this is Arlene. We are not doing that currently, but it's a great idea.
And I mention it because, I was going to say I mention it because sometimes, the primary care providers are a little farther ahead now, big systems like UW Health notwithstanding.
Most of our referrals are to one of the big hospitals nearby, and I kind of face the same thing Dave did.
Mm-hmm.
And so I think I had emailed Marnie regarding a list of providers in the area that did have Rev that we referred to.
Yeah, one of the challenges that everybody's going to experience with this inbound side of health information exchange, we talked about the referrals, and we're talking a lot about referrals, but it includes new patients as well. So patients you've never seen before that haven't been referred in, they need to have this process followed. And by and large, think about our patients that we see. The bulk of the patients that are going to fall into the denominator of this measure are going to be those new patients. So we're all going to need to develop processes to make these things happen, and that's going to probably be more defined as the year goes on. But that's also true of anybody else. Any other provider that's in the community that has a new patient walk through their doors, they're going to need to make this happen. And as they strive to figure that out and figure out how to make it happen, they're going to get on board with understanding how to exchange information electronically. And that's when you're really going to start to see these things start to happen a little bit more. But for sure, up until now, it's definitely been a challenge because there's been exclusions available all along. So it was real easy for providers to just say, well, I'm not going to do this. I'll figure it out some other time.
I know here in Maine, we've just started to have local providers send us, it's kind of a generic, we're required to send you this update because this is your patient and we have to give you a list of medications. However, it's not done electronically, it's done via fax.
Yeah, that's interesting. I've seen reports elsewhere of people like running into severe roadblocks where practices would say, stop calling me for med lists. So I wonder if that's a attempt to get around that sort of thing. But you make a good point about it needing to be electronic here in 2019. The paper-based processes aren't going to count in our favor.
So if a new patient comes in and they get on their portal from their primary care, and then we print that out, that doesn't count anymore then.
That's right, but they don't necessarily need to print it out, right? So let me jump into Rev for a second. Let me jump into a patient portal here too. So let's do a scenario where, I don't know how to set this up. Say I am seeing you, Dr. James,
okay,
and you are my eye doctor. I say to you, I just saw my primary care doctor. Oh no, I have to do it the other way. You're my primary care doctor. There we go. And I tell you, my eye doctor just diagnosed me with something and he put me on some medication, but I have no idea what it is or what I'm on. And you're saying to yourself, I sure would love to see that information. So that patient could log into their PHR. Okay, we're assuming in this case that I'm a patient of a doctor that uses Revolution EHR, so I'm logging into Revolution PHR, the patient portal. And then what I can do from there is rather than printing it out for you in office, I have the ability to send you the information. Okay, so I can use the send info here, and that's going to fire up a new message. And your name would obviously be here, but in this case, my name's here. But you can see up here at the top, there are two methods for the patient to get that information to you. And this is a kind of a sneak peek at 2015 edition stuff that's going to be in version 7 that comes out next week. The patient now, because of all the challenges that have surrounded direct messaging, patients are now required to have the ability to forward information to providers through standard email. So in that case, a patient could choose email and say, what's your email address, doctor? And they could type your address in here, and then their information would be sent to you in electronic format. And it could just be dropped into the patient record that way. So not only can they print it out like you suggested, but they can also do it in a way that's going to work for you scoring wise. Again, does a patient understand that right now? Probably not, but hopefully we'll see some progress there in time and understand that these capabilities are available. Does that make any sense?
Yes, it does.
Yeah.
I have a question. It's our understanding that email is not considered HIPAA compliant.
It is, that is correct. Now, I am not the doctor here, right? I am a patient. So as a patient, I have full authority over my own information. And if I choose to send it through email or hire a plane with one of those banners behind it that's going to put my health information broadcasted across everywhere, I can do that because it's my information. If I'm the doctor, I don't want to be sending information to other providers through standard email. But anytime a patient requests that information be sent through standard email and or they are the one sending it, they have the authority to do that.
Okay.
And this isn't I should also point out that this isn't a decision that Revolution made. I'm not saying we were opposed to it, but this is actually a requirement by the government certification program to make this capability available. So there's nothing shady about enabling a patient to send it that way. It's just providing them more flexibility and so making it easier for providers to get access to this electronic data that they need. Good point, though. Any other questions about I keep debating whether anybody would like to see what I mean when I say electronic document. Does everybody know what I mean when I say electronic document, or is that kind of a foreign idea?
We haven't been doing it, so.
Okay. Well, let me show you guys. I know we have like 15 minutes left. Let me show you. Okay. So let's say this patient was referred to me by another doctor, or we could even assume it's a patient I've just never seen before. Maybe that's an easier way to do it. You can see the record's completely blank, right? There's no diagnosis history or anything in here. So I'm really starting from scratch. And this is one of those scenarios where we're happy to see a new patient, of course, but we know we have some documentation ahead of us in transferring information over. So the idea would be, in 2019, if I receive an electronic summary of care, transition of care, or clinical summary document, and I have that as part of the patient record, I can go through a process where I can do one of two things. Either I can view that document in a human readable format, or I can actually process it and have the information added to the patient record. So if I was to show you the process, I highlight the document, and then I select Incorporate down here in the lower right. And when I do that, Revolution processes it, and it's going to present me with those two options of either viewing or continuing with this process. So I'll show you view, because I think you might be interested in this. At least I am. I think it's pretty neat. You'll see a little bit different perspective. For those of you who've seen a clinical document in electronic fashion before, you may remember it being all yellow and purple and having a hard time faxing it or what have you. It's just kind of difficult to read. Well, this represents data from that referring doctor or the other doctor the patient has seen from their medical record. So I can scroll through this And I'm going to see a lot of cool information, right? I can see the exact medications and dosage and everything about it. I can see their problem list. I could see if there was more information in this document, I could see the past care plans that the doctor had for the patient. So it's going to alleviate a lot of questions that we often find ourselves asking. A lot of times, I know from a coding perspective, we wonder, you know, what was the diagnosis that this patient was referred for? And we can find that out through a document like this. So you have the ability to even customize these documents the way that you'd like. So for example, if you didn't like the fact that some of this stuff was up top, you can actually set a preference at the user level to have, say, a reason for referral sitting right up top, so you don't have to go hunting for it. You could even decide that you don't want to see a bunch of this stuff. Like, these can all be hidden on initial launch of this viewing window. So you could have it set up just to show you the things that you want in the order that you'd like. So I think that side of it is kind of neat. But I think the other side of it, where you're following through with this electronic reconciliation process, is neater a word? I'm going to say neater. It's even neater. So here's that side-by-side view that I was talking about. We have the data from the incoming document on the left side of the screen, and then we have the patient record in Revolution EHR over here on the right. So I can see here what this patient has been diagnosed with by that primary care provider, and I'm in a position now where I can make decisions about what I want to be in my patient record. So if I said to myself as an eye doctor, you know, I don't really care about fever, I don't really care about chronic rejection of renal transplant, maybe I just want hypertension and hypothyroidism in my record, I can select these diagnoses and I can remove them from this list. And then when I select consolidate, I'm left with one master list, okay? If I do the same for these other categories, here you can see the patient's medications, and I have nothing in the patient record, so obviously I want those added. And then I have allergies here as well, so I'm gonna add those. Once I've done that for the 3 different categories that are available here, I can select confirm to add that information to this patient's record. So then when I head back to the patient's summary screen and I reload here, you're going to see now that the patient's diagnosis history has been updated, the patient's medication list has been updated, and if I go into the allergies component, you'll see that those allergies have been added. So that's why we're being pushed in this direction. Number one, from an efficiency standpoint, but number two, that's information that a provider has validated and built into their record system that's now being shared with you and being built into your record. So you can think about how the reliability of that information is enhanced through that process. So when we talk about this thing right here in the coming weeks, support electronic referral loops by receiving and incorporating health information, what we just saw there is what's measured by this individual measure. And then the other side of it, when you're sending a document to another provider, what you just saw is exactly why you're sending a document to another provider, so they can simply drop your information into their record system. More efficient, more reliable.
Britt, I do have a question about what you're showing us. One of the limitations that Dr. Snarvis and I have right now is the access. Sometimes because when we receive a document and it comes in at his authorization level, to be able to pull that in for us to download it and check it all in. And if I'm incorrect on that, please correct me. So will the authorization level change, or will it be coming in through a different method so that someone like myself, a manager, can get to those files and download them without the doctor's level of authorization in Rev?
Definitely. You could do that whole process yourself if you wanted to.
Okay.
You wouldn't need to do it. You can also handle the outbound side of it. So that's a big point that we're going to make in the upcoming weeks, is that these processes don't have to be done by the doctor. That they can be set up to be done by any sort of process that works for you.
Okay.
They also, I'll make one other point about that, Arlene, they don't need to be done at the time of the encounter. You know, it stands to reason that in a lot of these cases, especially these new patients that we're talking about, that new patient isn't going to come in a lot of cases and be able to provide you with an electronic file, right? We're going to find ourselves probably reaching out to a primary care physician or somebody else trying to get an electronic document. So from that, it makes sense that we can complete that process outside of the encounter. And that's true. We can do that at any point as long as it's done prior to the end of the year. So there's flexibility built into it to make sure that you don't have to do it during a set, very small window of time, because that's just kind of unrealistic.
Thank you.
Mm-hmm. I see a question there, Marnie, from Missouri. Well, it's more of a statement than it is a question, that struggling with primary care doctors not participating. And I assume that means either participating in the quality reporting program itself or participating with direct messaging. And that's not uncommon. I think that's what a lot of people on this call are sharing. And I certainly shared it for a while in our community till I just saw it almost like a dam collapsed and everybody had the capability. And I think that's what we're going to be seeing across different areas of the country as more and more people are finding their way into sharing information successfully and getting on board with the protocols that are needed to make it happen. So not a surprise at all to hear right now that it's a challenge, but I would expect it to get easier. So we're coming up on the end of our hour. I don't want anybody to not voice questions if they have them, or thoughts or concerns about anything. So feel free. We're not recording this, or are we recording this? Did we record this, Marnie?
Well, since we had such a big group, I thought I'd hit the record button just in case something really fantastic came out of it. So we are recording it. We could send it to those who couldn't make it.
I was going to make a joke that we are not recording this, so you don't have to worry about asking anything and having it being used against you in the future. But
yeah, can't say that.
That's not going to work now.
No. I would say that the questions you're asking are helpful for others who couldn't make the call.
And they've all been very good.
Mm-hmm.
I'm sure there are some good questions still out there. But next week, what we're going to do, just to give a little bit of preview, is we're going to talk through this scorecard again. And we'll look at it in Revolution EHR. And we'll talk about the way the scoring situation works, meaning what happens if you can't be successful on a given measure? Does that measure have an exclusion available for it? And if you end up using the exclusion, what happens to those points? That's kind of what we'll dive into next week. And then starting the week after that, we're going to hit that health information exchange objective pretty hard. We'll carry on the discussions that we sort of started here today.
And is that like the 28th that you're looking at doing that one?
That sounds right. I don't have a date available to me right now. How weird. I don't even have a current, it's the 7th. So that would be what, the 21st and the 28th. Okay. So the two measures of health information exchange would be covered on the 21st and 28th.
Yeah, I was just going to double check. Well, yeah, we'll be in your feed, so to speak, every Tuesday with an email message and then a follow-up office hours on Thursday of that same week. So, yep, the 21st and the 28th is when we'll dive into referrals in and out.
Toward the end of our data submission process for 2018, do you want to talk a little bit about that, Marnie?
Oh, sure. Yeah, you'll hear from us again tomorrow with an update, but we're closing the gap toward the end of all of the providers in the RevAspire community. So we've been moving hard on data submission and getting preliminary scores based on what the QPP website has told us. So we will send you, like I said, an update on our progress. And when we have everything all submitted, we'll do what we did last year, which is create a report for everyone to show what the preliminary score is, knowing that CMS doesn't finalize that until the summer, and then how that compares to others in the RevAspire community. And then we'll follow that up with a live webinar to talk through everything. So we got a little bit of like one foot in 2019 performance period and finishing up our 2018 performance period and reporting. So we're getting there. And it's only February 7th. Feels good.
Thank you for covering me on that.
Mm-hmm.
had a
A little bit of a dog problem.
yeah, we had a little bit of an issue. So, I mean, we're getting close to the top of the hour. So I will say that, again, if anybody has any questions that they didn't feel comfortable voicing here during the discussion, please feel free to send them to us. As always, our address is RevAspire at rev-360.com. And we'd be happy to talk about anything at any point, but we think a lot of these things are going to become clearer in the weeks ahead as we go over each of these things, each of these measures.
Is there information for the referral loop on the sandbox?
There is information on, I mean, there's a little bit of information about direct messaging in general in Rev Help, which you can access through the Sandbox Help menu. But where I would probably point you is, let me get out of this real quick again. If I point you to Insight, that's our customer portal, if you haven't seen it before. It's insight.revolutionehr.com, and I believe you can also access that through the help menu. Okay, there's a little thing right there that says Insight. If you head into the MIPS thing over here on the left part of the screen,
Okay.
and then I select Promoting Interoperability, which is what we're talking about. Mm-hmm. There are explanations of each of the associated measures that we highlighted, on the grid today. And if we go into, say, support electronic referral loops by receiving and incorporating health information, you'll see an explanation with some screenshots, and then there's also a quick video down at the bottom discussing the measure. I think it's less than 10 minutes long.
Okay, thank you.
You're welcome. There's also one for the flip side of it, sending health information. Well, with that, I mean, if there aren't any other questions, Marnie, Libby, any thoughts in closing?
No, I think it's good that we get multiple stabs at understanding what these measures are. So, like I said, we recorded this, so if you feel like you might need to watch and listen again, we'll have it for you. All
right. Well, again, let us know if you have any questions, but otherwise we'll see, hopefully get back together with you if you can make it next Thursday. And as Marnie said, keep an eye out Tuesday morning for our message that will cover what we're going to be discussing that week. So thanks again for your time today. We'll talk again soon.
Thanks, Brett. Thanks, Marnie.
Bye-bye.